Welcome everybody to today's BDHP COVID-19 Roundtable Discussion. I really appreciate everybody making time today to attend this meeting, and I think we've got a really interesting set of speakers to present today around mental health and wellbeing, which is a really very important topic for the system at the moment as we continue to deal with the pandemic. So I'd like to start today by acknowledging the traditional owners of the land. I want to pause and reflect on the fact that we're meeting, albeit virtually today, on custodial land of one of the oldest living civilizations in the world. So I'd like to start by acknowledging the traditional owners of the land of country throughout Australia and recognise their continuing connection to land, waters and culture. We pay our respects to their elders, laws, customs and creation spirits, and I extend that respect to any Aboriginal and Torres Strait Islander peoples on the call today. Brisbane Diamantina Health Partners acknowledges the important role that Aboriginal and Torres Strait Islander people play within our community. So BDHP's role, BDHP's role is really to support the connection of efforts that individuals and organisations and communities have in our system in Queensland with the idea of having better health outcomes. Our partners are health, research and education leaders who combine their strengths with state-of-the-art facilities to solve major healthcare challenges. Our vision is really clear that to improve population health outcomes, we do this through collaborative partnerships that translate discoveries and knowledge really rapidly into practice. So some principles for today's roundtable discussion. I recognise some of you will not have been on one of these calls before. Ideally, these sorts of meetings would be held in a workshop style with people able to attend in person, but we're not able to do that. But BDHP, working within the community, really felt that it was important that we could provide these roundtable discussions. And so the intention for us really, as noted here in the principles, is to do everything that we can do, but not to get in the way. And so I want to in particular note our healthcare workers at the front line who are engaged in the COVID-19 response. So as noted, the system is really focused on coordinating the response at the moment. And so we're working to support translational research, coordination and collaboration. And the focus of our presentations, with this one being our third roundtable discussion, is really on the translational research that is going on in the system. And so today we have a theme around mental health, and we've got a series of speakers that we'll introduce in a minute. So just a few housekeeping notes on the meeting, and then we can get on with the presentation. So we're using a Zoom meeting, and you will, if you're in, then you realise that you've come in and connected on Zoom. We have got security in place in that we're monitoring the folks on the call. We're making a note of who's joined, but we have run this session as an open, effectively public event. That has been our approach. We'd appreciate if everybody can mute their mics at their end, and if possible, if you could switch off your video. That's largely to do with performance of the system. But obviously when we're having discussions, we're very keen to get your feedback and have you present. But if we could do that, we think we can save some bandwidth. It's really important that you note in the Zoom application, there is a small button that you'll see at the bottom around the chat, and we're really encouraging you to chat over the course of this call. That's one of the key ways we want to make sure we can get information and questions and discussion going. The other thing we'll be doing in the session is to be using a little interactive application. And so if you can get your mobile devices ready or a browser window, in a minute we'll put up a question and we'll ask you to go to a URL. If you can type in menti, menti.com, we'll give you the passcode in a session, and then we'll have some questions that allow you to interact in this discussion today. So this is the link to the group contribution tool, and I'll just get that going while we're going here. Okay. So when we, you should be able to get into the Menti screen now that I've started that presentation, and you'll see the first question there. So it's probably a good place to start. And today we really want to understand the roles. So I'm just going to swap my screen over for a second. Bring up this one. So this is the question that we're going to start by asking. So if you go to menti.com and use the code 570593, oh, awesome, people are doing it. What's the role that you, for people who are on the line today, we're really interested to understand your role, your primary role or contribution in relation to COVID-19. And so a little word cloud is going to pop up on the screen as people start to enter that information. So obviously research is going to be a really topical point for us today. Roles around mental health, which is one of our key things today. I see primary care in there, research governance and compliance. So this is this little tool will let us get some feedback during the day. For us, this is still something that we're working out how to use. And so I'm really keen for you to provide feedback, and we'll have a few other opportunities throughout the conversation today to get your feedback and to use this tool. Excellent, that's really great. So I'll move us on to the next question in that slide set. So the question then is, what do you personally want to get from today? Now, we're very interested to make sure that these sessions are useful for people. This is the third one we've held now, and we were able to get really great feedback and input from people on what they'd like to see BDHP do, and in particular in these sessions. And once again, I've got a few slides I'll do in a minute just on how that's actually translated and how we've taken that feedback. So if you'd like to just add into this form today, what personally you'd like to get from today, you should be able to start adding your information in. Oh, and here it comes. Great. So I'll just keep that going for a bit. Collaboration, potential understanding, current research. This is really important. We've got some really great speakers today who'll be able to outline the research that they're involved in and research that they're aware is going on. And we've tried to get a spread of that research in terms of both, I guess, the broader community and the issues for mental health in the broader community, but also importantly, the well-being of our clinicians who are faced with managing the response and dealing with this crisis. I see on there networking potential as well. That's another really good one. And so what we're doing is trying to make sure that we can provide that contact and support that collaboration. So on our website, when we provide this information, there's links there to be able to get more information and contact us, and we can put you in touch with some of the other people that are presenting today. And there's I think a good opportunity for potential collaboration coming out of these sessions as well. Okay. Well, that's really good. So we obviously collect this information. It comes up through this little tool, and what we do is we take this live information and we put that into the presentation deck that we're using today, and then we make this deck available. So you'll be able to see all of this information as it comes through into the video that we're recording today, and also through the system. So I'll stop there, and I'll just move us back onto the presentation. Excellent. So you should all see the next screen there where we were talking about roles and what we wanted to get from today. So the next section is really the feature of the discussion today. And I've got one or two slides just to briefly give you an overview of how the roundtable discussions have travelled to date. Then what we're going to do is we'll work with our speakers. So we've got 3 topics today. The first is around promoting wellbeing of critical care doctors, and that's presented by Dylan Flores. The social cure, presented by Yolanda Jetton. and also research projects with a connection to mental health, which is going to be presented by Shane. And we've got some more information about these speakers in their intro slides. So I'll get on with the next slide, which is really a bit of an overview of where BDHP has gotten to or come to today. So we held our first update earlier in the year, and the initial roundtable that we had had a focus around infectious disease and the virology response and the development of the clinical trials. And we had speakers present on that information. And what you're seeing on the screen here is these little fact sheets, if you like, or infographics that we prepared that capture that information. And we'll do another one based on today's conversation as well. So that first one had a very lab-based, and clinical trials focus. We talked about biobanking, and there's obviously still work going on around developing biobanking solutions where there's an opportunity during the COVID-19 crisis to be able to, collect those samples, but make them available to researchers. There's ongoing work there. In the second briefing that we had a few weeks ago, we took a focus around aging, but also to understand social applications and apps, and also what was happening and featuring some of the work going on in the health system in terms of, what I would call innovation at the coalface. I really wanted to see that where we have clinical researchers who are at work in hospitals every day, and the sort of innovation and activity that was going on there with partnerships with the universities and with the hospital and health systems as they were preparing in terms of things like protective equipment, but also other options around how to manage the data, especially in terms of ICU data and other really valuable data sets. And once again, those conversations continue to go along. I should also let you know that we're planning a reprise of the first session that we held. So next week, we're looking to hold a session where we'll go back over some of the content from the first one and see how those clinical trials and that vaccine development has continued to progress. The other main thing that really came out of the discussions and what we learned in round one in the first discussion and the second one was around what sort of content that BDHP could put together and make available on our website. So this is just a very quick screen grab of that site. In there, what you'll see is we've got some really interesting blog information or strategic commentary, if you like, coming in from Frank Gannon. So Professor Gannon is currently based in Ireland, but is continuing to monitor, obviously, the COVID-19 outbreak. And he has a really interesting perspective, given the location he's got in Ireland, but also his understanding of the system here. And Frank continues to develop content and provide commentary, and we're making sure that that keeps coming through in a timely manner. Staying up to date with these roundtable discussions, so you'll find links there to the videos that we've recorded of these discussions and also of the materials presented, and there's links there for any contact information. We've collected primary resources. Now, we recognise that a lot of these resources are out there and well known. We sought to support our community by putting primary resources together. Obviously, all of those resources point off to the authoritative sources, so we're not trying to maintain those things. They link off to the Department of Health's main response pages and information about NH and MRC and the like. We are trying to make sure that we're keeping funding and grant opportunities on the website and making sure that as we continue to work with the Australian Health Research Alliance and interacting with MRFF and NH and MRC around the current projects that we have, that we are bringing any timely information via the website to our community. Finally, there's some information where we feature some of the BDHP partner information in the news. So if you've got stories you'd like us to boost, we'd be very happy to do that and very keen to promote the work that's going on within the partnership and the members. So now what I'll do is I'll hand the screen over to Associate Professor Dylan Flores, who works at Metro North Mental Health Service in Queensland Health. Now, Dylan's going to use his slides because he's got animation and some slide transitions in his work. So I'll stop sharing now, and then Dylan, if you're ready to go, you can present your slides.
Sorry, just one moment. I'll just bring up the slides.
Good one. Thanks, mate. Excellent. Thanks, Dylan. So I can see your slides and you're off mute, so I'll hand over to you.
Okay, thank you. So I'm a psychiatry advanced trainee working at the Royal Brisbane Women's Hospital, and I'm just going to walk through an initiative that our collaborative has been working on, aiming to promote wellbeing of critical care doctors during the COVID-19 response. This is building on this existing partnership that had developed between Metro North Mental Health and the Critical Care Research Group over the last couple of years. Before COVID, what we were really looking into was redesigning the intensive care unit, and the idea is to modify the environment and see if providing patients with a better experience helps to improve their recovery. And that's led on to further research looking at how patients recover after a severe illness. And when COVID-19 started to hit, there was this rising level of stress among staff in critical care. And through that partnership, particularly from intensive care, staff were able to reach out to Metro North Mental Health and were able to kind of say that they were needing some support. And when we had a bit of a further look, we found that actually staff were reaching out publicly asking for support as well. And in particular, what they're asking for was a kind of peer level support from their mental health colleagues during COVID-19. And since that started, then we started to see in the media that this is not isolated to Australia. This is quite a widespread issue, that there is a lot of distress among critical care staff, and that the effects of this are actually quite serious. So in terms of the response, we formed a small steering group to sit down and discuss what kind of response Metro North Mental Health could provide to its critical care colleagues. So this initial group consisted of a few people from mental health, myself, James Scott, Sue Patterson, as well as some people from critical care, so people like John Fraser and Renee Saba, and then some people from the anaesthetics and emergency medicine as well. And what we wanted to see is really what was happening at the coalface at that time, and what kind of response from Metro North Mental Health is going to be most helpful and the most accepted by critical care. We had a look at the literature, and this was in the early days of COVID, particularly COVID for Australia. So there wasn't a lot of literature around that yet, but we did have some really good literature that had come out from the SARS pandemic that we were able to kind of build a preliminary model of what this response might look like from. We then took that to Brett Emerson and to the Metro North Hospital Health Service exec to get their kind of preliminary endorsement of this idea, and then went about forming a multidisciplinary focus group. And the idea was that this is something that was going to be available across the Metro North Health Service. So we needed representation from all four of the hospitals, Royal Brisbane, Prince Charles, Redcliffe and Caboolture Hospital, and from all of the major stakeholders. So all the departments, emergency medicine, anaesthetics, intensive care, respiratory, psychiatry, the legal department, representation from exec, and we even got some consultation from the psychology service, the fire service and the ambulance service to sit down. So we had a meeting with over 30 people in it to discuss taking that preliminary model, what would this look like, and to troubleshoot any challenges that we might face along the way. Overall, from the time we recognised that there was an issue here to address, it took us about 4 weeks to develop the response. And the model that we came up with is really based on the Swiss cheese model, where you've got escalating levels of distress and an escalating level of response, or a different layers of a safety net available. So at the bottom level, we have general information that we're able to disseminate to staff in these departments about what it's going to look like as the pandemic happens, the different phases that are going to occur, the kind of stress response people might have, and some helpful tips around that. And we found this really helpful poster from the Intensive Care Society that we were able to disseminate around that. At the next level, and this was something that really came out during the SARS pandemic, was the idea of having a group huddle at the start or an end of a shift, where the team were able to kind of discuss the plan for the day, discuss what happened over the day that had just been. And that seemed to really help to build a sense of cohesion among the team, as well as a kind of sharing of the burden or the responsibility for what's happening, and also help to kind of reduce any bullying that might occur in the department. The next level was a buddy system. And the idea here was to find somebody at the same level and doing the same kind of job as yourself, who you are paired with, and you have a responsibility to check in on that person, make sure that they're okay, and that person also has permission to not be okay in front of you. and you're going to be talking to someone who really understands what you're going through at your coalface. They're at your level, and so you're going to feel safe to have that kind of discussion. And then finally, at the top level, if there's a level of distress that isn't able to be managed within that kind of peer-to-peer support, we have a peer support hotline that these staff could access. And the way the peer support hotline works is that it's available Monday to Friday during business hours. It's available to senior medical officers working in intensive care or emergency departments in Metro North. And it is operated by a group of 10 psychiatrists that are volunteering on a roster system to man the line on top of their usual business. And the level of response that they're providing is very much at the peer level. So this is talking to a colleague about the difficulties or the challenges that you're facing, and they're able to provide a sympathetic ear and some psychological first aid. Usually the idea is that they'll be able to kind of manage the situation in one phone call, but they may be able to offer a follow-up phone call. And the idea is that this is all something which is confidential. If it's seen that this is something which is going to take more input than 1 or 2 phone calls, then the psychiatrists are able to suggest some self-referral options to the caller, including their GP, an external psychology service that's available 24 hours a day called Benestar, the Doctor's Health Advisory Service, which is also available 24 hours a day. And there's also a group of private psychiatrists which have offered to bulk bill health practitioners who are experiencing distress during COVID. After we set this up, I got in touch with Dr. Ben Cheng. He's a psychiatrist working in America, and he had set up 2 similar systems, one in China that dealt with the original Wuhan response that was delivered through an electronic medium, and he set up a phone hotline similar to what we've done, which is available across the entire of America. The good thing is that the call volume is low, which is what you want to see because this is the top level at that last piece of the Swiss cheese. So he was receiving about 80 phone calls a week across the entire of America. After we set this up, of course, there was responses happening across Australia to try and address COVID, and the curve has been flattening. And I've been keeping a regular contact with key people in each of the departments that we're offering this to. And what they're reporting is the level of distress is generally decreasing. They kind of went from a phase of feeling uncertain about what was going to happen, what's it going to look like for Australia. Then they went through a phase of what they described as preparation fatigue. And now that's kind of really reducing, and they're starting to prepare to go back to something that looks a bit like business as usual, although in the back of their mind, everybody's kind of thinking about whether or not there might be a second wave at some point. And the final thing that we've been doing is we've been sending out an international survey because we're very interested to see how what we're seeing here at our coalface compares to other critical care health workers around the world. And so we've got this online survey, and I'm happy if there are any critical care workers on the call today, I'm happy for you to access this link and just provide a brief survey about what the level of distress is like, what the level of demand on your service is like, as well as what kind of response has been happening on the interpersonal level, as well as at the service level. And the idea is that we'll be able to then compare and get any good ideas that are happening elsewhere. So that's everything I have. Thank you.
Thanks, Dylan. So what we might do is we'll finish the slides, but I think we've got an opportunity for some questions. So if you have a question for Dylan, please put it through to the chat window now. I'm just not mindful of how many people we've got on the call. So I'd prefer if you can just pop your chat up, and then what we can do is maybe just bring you up. So we've got about 40 people on the line, so I'm be hesitant just to sort of open up, but obviously we're getting the link, and Dylan will make sure that survey link goes onto the BDHP website as well. Can I ask you, how long is the survey going to be open for?
We're aiming to get at least 200 responses. We're sitting at 41 at the moment.
Okay.
It takes less than 2 minutes to administer, and we're interested in anyone who works in critical care. So that includes admin officers, anyone who works in that space.
Yeah, terrific. Okay. We've had a question come in, interested in how much guidance and structure was given to the team huddles.
So the main thing that we wanted to do is to allow each individual service to tailor the way that looked to their service, because everyone has a slightly different culture, everyone has a different workload, and the people who knew how to do that best are the people that work there. So what we had is a representative from each department. We were meeting weekly and discussing the way that it would be administered. And so each of them did it in a slightly different way and then fed back how it worked.
Yeah, that's really interesting. So there's some really positive comments coming through about the initiative. I'll wait to see if we get a few more questions, but we'll give that another minute. But Dylan, if you don't mind, I might ask you one myself. And I guess that's really around, I'm interested in where you see the survey and this work going in terms of development of, I guess, research concepts and how they may transition into clinical practice, because obviously something critical and such an acute event like this is always going to, provide lessons that once the COVID issue is over, that there's opportunity to bring lessons and learnings into this. So with your experience and your work in the hospital, what do you think the opportunity to develop, research and then clinical practice change might be?
So the first thing that we're wanting to do is to publish the process that we went through to set this up, the challenges that arose during that and how we overcame them, to provide a roadmap of how we came to the solution that we did, as well as what that solution would look like. This is the first pandemic of this scale in 100 years. It won't be the last. And so having a roadmap available for the next time something hits, whether it's at this scale or at a smaller scale, will allow for us not to lose those early weeks into developing something. I'm reminded of that old phrase, in times of peace, we must prepare for war. The other thing that we're planning to do is, when the dust has settled a bit, we'd like to conduct some qualitative interviews of staff about the response, the initiatives, and so that we're able to kind of publish what that looked like, the different phases of it, and what was the most helpful, and how that compares internationally.
That's terrific. Look, we've got one more question and then we'll move on. So the questions come in to saying, interested to know if there's been an increased awareness of ICU impact on patients and families, including the role of staff stress on patients and families. So that's an interesting question about the dynamic of the staff stress and what that has onto patients and family members.
It's probably a little bit early for us to know. We're trying to not be too obtrusive on the wards at the moment. Interestingly, what I have found from the survey so far is the other way around. So internationally, there are a number of places where they have a much higher mortality in ICU than what we're seeing so far. And it's in a place where family members aren't able to visit the ward. And it's actually been a source of stress for staff, seeing people pass away without family having a chance to be there to say goodbye. I think that we're going to find out a lot more about that as things slow down and we get more of an opportunity to ask those questions.
Thanks, Dylan. That was really terrific. Thank you very much, and well done. Congratulations. I think there is a lot of really interesting information that you'll get from this. And as I said, we're very happy to promote the survey. So thanks for presenting this morning. And what we'll do is we'll make sure if there are any inquiries that come through, we'll pass them on to you. So now what I'll do is I'll introduce our next speaker. Let's bring up the slide. Okay, so our next speaker is Professor Yolanda Jetton from the School of Psychology at the University of Queensland. Now, Yolanda's slides are also going to be ones that are best served with her carrying them out. So Yolanda, I'll stop sharing now, and I'll hand it over so that you can share your slides and your presentation.
Thank you. Let me just get this going. Sorry.
You're right. We're in the hands of the technology gods, so far it's working really well.
Okay. Are you seeing this?
Yes, we are seeing your slides. Thank you.
Okay, good. All right, thank you for having me today. I really appreciate to have the opportunity to talk about some of the work that we've been doing over the last couple of weeks. And I thought to just start with a little bit of a brief background before talking about the recent surveys that we've been conducting. Okay, so I'd like to start with just a very simple sort of exercise. If you look at these 11 factors, you all recognize them as the things that are really important, either preventing you from falling ill, but also from early mortality. And I'd like you to just perhaps have a quick look at them and think of the top 3 that you think are really the most important when it comes to predicting early mortality. So it says things like, smoking, being obese, air pollution, support, medication, etc. Yeah, I won't give you too much time, but all right. What I'd like to show you then is how these 11 factors were ranked on the basis of this meta-analysis that Holt Lundstedt and her colleagues conducted. So as you can see, they had over 148 studies, over 300,000 participants. And so what you will see, everything goes according to plan. No. Yeah. So 11 is the least important is air pollution, taking appropriate medication, and being obese. But if you look at the top 3, you can see number 3 is not smoking. Okay, not surprising. But perhaps the top 2 are a little bit more surprising. It is whether people receive adequate social support and whether they're socially integrated. So interestingly, out of these 11 factors that were studied, it seems to be much more the factors that have to do with having a relationship with others, not so much all sorts of other behaviors that we typically associate with health and physical health in particular. Okay. And this has certainly also been a bit the focus of our work over the last couple of years. So this is a study that Nick Steffens at the School of Psychology conducted. He looked at the ELSA, which is the English Longitudinal Survey of Aging in Britain. He looked at, in this very large sample for participants who retired, and then 6 years later, he simply looked at whether they had died or not. And what he also had for these participants is how many groups they actually belonged to when they retired, and 6 years later, how many they belonged to. So what you can actually look at then is participants who lost 2 group memberships over those 6 years. Their chance of dying was 12% and a bit. It reduced to 5 and a bit if they only lost 1 group. It was 2% when they had maintained membership in those groups. And you can see here slight positive, at least negative effects if people had actually gained group memberships over that 6 years. So what we actually have there is, quite profound evidence that belonging to groups is actually protective of health and predicts early mortality. And of course, what he did here is control for a whole range of other factors at time 1 that could have affected whether people were able to join groups, for instance, their physical health at time 1. So the effects that we actually witness here, the effects of being connected, belonging to groups is quite massive. And I always like this quote, which is from Putnam in 2000. He reviewed all of the evidence, and this is the conclusion that he came up with. As a rough rule of thumb, if you belong to no groups but decide to join one, you cut your risk of dying over the next year and a half. And just to give you an example what that means, he says, well, if you smoke and belong to no groups, it's a toss-up statistically whether you should stop smoking or start joining. Okay, and why is that then? Well, the reasoning that we have actually sort of been pushing for in the last couple of years is that we say, well, basically humans are social animals. So whatever we do, we often do that with others in groups. And by being with others, we actually find a certain sense of meaning, of purpose in our lives. It provides us with a sense of identity, and it helps us to navigate through life. So not surprisingly, being connected to groups has a very important influence on mental health. But of course, there are so many people who are not well connected and don't have a lot of groups that they belong to. And I just thought to quickly show you these data that were collected by the ABC in the Australia Talks series. My colleagues Alex Haslam and Kath Haslam and Tegan Cruz got hands on the data on loneliness. And as you can see here, with quite a representative sample of Australians, you can just see how massive the issue of loneliness is. Half of Australians feel quite lonely, and only a little bit over half report rarely or never feeling lonely. And interestingly too, and perhaps something that you may not have expected, we always talk about older adults being most prone to loneliness, but it's actually young people who report more loneliness and see it as more as a problem than older adults. And also, of course, there's a very strong effect of income. The wealthier you are, the less likely it is that loneliness is a problem. Okay, so this is a bit the background. And of course, when the coronavirus hit, our first thought was if people are stuck at home, if they have to stay indoors, then, well, that also has very important implications for the extent to which they can remain connected. And in the early days, this was mid-March, I think, we had 730 Australians from all over the country. It was a panel survey. And we asked them lots of questions. What we first of all found very strong effects that people who were chronically lonely were very worried about self-isolation. They also felt more generally less in control. They were more overwhelmed. They felt helpless, scared, and they were vulnerable in many, many measures. Interestingly too, we looked at age effects. We asked them lots of things about, did they want to avoid crowds? Did they want to wash their hands, social distancing, all of the behaviors. We didn't find age effects there, no correlations with age. But on trust, younger people were less trusting of government. In terms of isolation too, younger people were more concerned about loneliness associated with having to self-isolate. Sorry, my screen is actually just a bit covered. So when considering how lonely one would be if one would have to self-isolate, younger people thought that they would be lonelier. Okay, a few more findings, and this is just agreement with items. The younger the participants, the more they actually agreed that, that they would belong to groups that panic about COVID, that there wasn't enough information, that the situation is out of control. They were more about feared about worst case scenarios. And that they could do nothing. So all of this is quite negative type of response. Sorry, I'm actually struggling to continue to the next screen. So, but also fear that COVID is pulling us apart. But the younger the participant, the less they were to agree with more positive statements. So that's actually just a mirror image of what I mentioned before. Less trusting of government, that they would handle the crisis appropriately, less trusting of media, less sort of feeling that there's enough high quality knowledge. Also a bit more critical of family response, of the response of Australia, But, and this is of course interesting, this despite the fact that they are not feeling personally at risk from COVID. Okay, so just to give you a little bit of a flavor of those data, and we're still analyzing a lot of those data. We also collected data in 10 other countries all over the world, especially the harder hit countries in Europe, Italy, Spain, France, the Netherlands. We also have data from the UK, from the US, and also from countries like Indonesia, China, and Thailand. So we're still analyzing all of that, but I hope to have a more complete picture of some of this down the track. And we're also planning a follow-up to sort of look at how now most people are coming out of it and restrictions are being relaxed, how in particular mental health is faring for all of our participants that we contacted in March. I just want to finish with this particular sort of, well, it's an app that we developed, an online program. So my colleagues and I, we've been doing quite a bit over the last year in working with people who are chronically lonely, and how can we actually get them out of social isolation. That's the Groups for Help program that Catherine Haslam developed at the School of Psychology. I would be happy to talk more about that if people are interested. But for now, I just thought to sort of alert you to something we've been working on for the last couple of weeks. So if it is clear that the coronavirus has meant that it is hard to socially connect while physically distant, well, how do you then connect with people, right? How do you actually overcome that? And we are being told all the time that we, yes, stay connected, but at the same time, there's this issue of how do you do that? So what we had was a very short 10 minutes sort of online program that people go into. They are asked to list the groups that they belong to, the people that they interact with on a daily basis, and then to set some goals, 2 goals for, you know, which are the groups that you actually haven't really been connecting with now that you're staying at home, and think of a way in which you can connect with them still. So, okay, you may not be able to meet up for your weekly meeting, but you can perhaps give them a call, or you can organize a Zoom meeting, yeah? We tested this with UK adults, and this is just some of the initial information that we have, the feedback on the intervention. So people said, yes, it does. It's useful, just this 10-minute little exercise where I do some goal setting. People also rated their ability to stay connected with others a bit higher after going through the 10 minutes than before. And importantly, I think with many of them, we managed to track them down 10 days later. And you can see that many of them said, yes, or at least 50% of them said, yes, I've been able to follow up on this, and I have been doing what I actually set myself as a goal, and that actually feels good. So it is just nothing earth-shattering that we're doing here, but it's just in these times when the normal ways in which we normally connect with people is no longer a possibility, that it may actually help people to set goals and think of more creatively about how to stay connected. Okay, I think my 10 minutes is up, so I better sort of leave you with this. Of course, I was talking about a team. These are all of the people that I typically work with, all at the School of Psychology at UQ, and Tegan Crew is at ANU now, but also there are many, many PhD students and postdocs involved in it. So I just want to acknowledge them too. Thank you.
Thanks, Yolanda. That was really, really interesting. Really great work. I'd be fascinated to see the results of the study as you keep going and see the responses, people's attitudes change over time. Be great to be able to, the great thing about the app, I think that idea is, you know, in the future, we're more connected, but it means that real-time data in an appropriate privacy sort of centric way is available. So when the government's making decisions, I really like the idea that there's feedback from people about how they feel, because they're an important part of this, obviously. So thank you for that. That was really terrific.
Thank you.
I'm mindful of time, Yolanda, so I might move us on to the next speaker. But if we get some time at the end, we'll try and get some questions. But obviously, if anyone has any questions, please let us know. We're very happy to put you in contact, and collaboration around this is a really important one for sure. Okay, so I'll reshare my screen. So our next presenter is Dr. Shane Warren. So Shane's actually has provided his slides. So Shane, you don't have to panic. I'm going to run the slides from here. There's no tricky transitions for your slides. So if you just let me know, I'll basically move along for the slides. So I'd like to welcome Shane to present today. Shane's from the School of Public Health and Social Work in the Faculty of Health at the Queensland University of Technology. So Shane, if you're online, now is the time, and you let me know when you want to move the slides along.
Sure. And thank you very much for that introduction, David. And I'd also support your earlier comments about acknowledging traditional owners of the land on which we're all meeting, and elders past, present and emerging. So I'll move quickly through my presentation this morning, and I really wanted to talk through three research projects that we're commencing that have a connection to mental health in a very broad way, but still a very important way. So if we could move on to the next slide, please, David. And yeah, I've just done that. So on to the next slide again. So the three research projects that I wanted to cover this morning were a piece of work that we're doing in partnership with the Centre for Justice around domestic and family violence during COVID-19 era. And I'll talk in a bit more detail about that in a moment. The next two projects are to do with social isolation and also emergency relief assistance that's administered by a number of non-government organisations. And both of those projects are going to be undertaken through our field education team and master's level students. So if I could just get you to move on to the next slide, please, David. So domestic and family violence during COVID-19, we're really interested and have been very interested in this topic for some time, and growing awareness across society around domestic and family violence, and probably since 2015, and Dame Quinton Bryce's Not Now, Not Ever report putting an end to domestic and family violence in Queensland, was a major impetus in terms of our understandings of domestic and family violence. But certainly from that time, there's been a lot of activity. And certainly in recent months with COVID, we're hearing from women's safety organisations, peak agencies, both in Queensland and also in other jurisdictions about risks and also vulnerabilities around domestic and family violence. Certainly the early indications are that rates of violence are escalating because of isolation, because of vulnerability, because of difficulties accessing support services. And certainly advocates have reported increased complexities and challenges in assisting victims and survivors because of the different restraints on people's movements. There's also issues around technologies, and that's going to be a focus in this particular research project as well. If I could just get you to move to the next slide, please, David. So we're going to be doing a small pilot project, and then with the view to doing a larger scale research project next year. But we're very much interested in the questions around have rates of domestic and family violence and service provision been impacted by COVID-19? And within that, looking at housing impacts, access to community services, capacity of services, etc. What do we understand as the key drivers for changes in rates of domestic violence, linking to the issues of social isolation, restrictions, financial stress, loss of employment, etc. We also want to explore issues for particular cohort groups, including the lesbian, gay, bisexual, trans, intersex and queer group, culturally and linguistically diverse backgrounds, Aboriginal and Torres Strait Islander survivors, and those people living with a disability or experiencing a disability. And we also want to focus in on digital and communication and internet technologies around supporting people experiencing domestic and family violence. So there are our research questions, and look, where we're at to with that right now is we've obtained our seed funding. A research team is formed between the Centre of Justice and the School of Public Health and Social Work. We're in the process of seeking our ethics approval. We plan to go forward with our Qualtrics survey in the next couple of months to specialist domestic family violence service providers right throughout Queensland, right from the Cape all the way down to the Gold Coast and out west. We want to target not only specialist domestic and family violence service providers, but a lot of other generic agencies, including housing providers that we think are really relevant to this particular research. And we'll be working towards a briefing paper and research report later this year. And as I said before, planning to do a longer research project next year. So that's the domestic and family violence research project. I just wanted to touch on two of the other, if you could move to the next slide, please, David. The next two projects are going to be conducted through our field education services, and it was just great listening to just the previous presenter and her comments and remarks about social isolation and some of the findings from the research that's been done there. But I guess as a result of some of the limitations that we are experiencing around being able to place students as we ordinarily would, we are thinking creatively and differently about different ways of students doing their placement. And this particular project is just working with the community, Queensland Community Alliance, around their ongoing social research and social action that's specifically focused on social isolation. And this work building towards their objective around a parliamentary inquiry into social isolation. And I mean, this is a piece of work that's been ongoing for the QCA for some time now, and particularly around understanding the issues of social isolation around different locations across Greater Brisbane. So we're particularly interested in working with this organisation around, the more recent experiences around COVID-19 and how that fits with some of the work that they've done already. So that is the first sort of project that we'll be doing through our field education team. If I could just get you to move to the next slide, please. Look, the next research project was around emergency relief and assistance. We ordinarily have a lot of students doing placements on the front line of welfare organisations, providing emergency relief, brokerage funding, a whole lot of other related case management type services. And we've been hearing from a lot of the NGOs that we work very closely with around the pressures on their emergency relief and assistance schemes. Some of those funded by Commonwealth and state governments, and some of them are actually privately funded as well through other charitable avenues. So we're particularly interested in doing a focused piece of research around the pressures on these schemes, the types of assistance that people are seeking, and also understanding some of the new and emerging cohort groups that are presenting to these frontline organisations. So we're hearing anecdotally that there's growth in the area of international students presenting to these organisations for food and for practical and for immediate financial help, and people experiencing housing and financial stress. And also people with mental health concerns. So the focus of that will be building towards recommendations for service delivery and practice, policy and program design. So yes, that will also be done through our master's level students on placement next semester, and working with a range of NGOs in doing that. I think that concludes, David, what I was hoping to talk about this morning. So I hope that sort of brings you in a few minutes, with a few minutes to have general questions.
Thanks very much. That was very interesting, and yeah, it's I'm a bit lost for words because it's such an impactful area. I will ask just quickly what your interaction around primary care, because obviously, integration with primary care is a really important part of this, and I think this really highlights the social work aspects of this. So just briefly, what sort of connections have you got, say, through the primary health networks and the support that they've been doing? I know they've done a lot of work in this space.
Yeah, so certainly with the first project on domestic and family violence, we would be wanting to include members of that network in our survey that we provide, and certainly, absolutely recognise that throughout Queensland Health and the health care system, a lot of key stakeholders that have a very important information for us around domestic and family violence, and I'm very aware of roles, in relation to different services and high-risk teams around the state as well. So we would absolutely want to capture their perspective in the survey.
Yeah. Okay. Thanks very much. Look, I'll just have a very quick look at the chat window, just to see if there are any quick key questions here. So just very quickly, Jenny Strong is the Executive Director of Research at Metro North, and Jenny makes the point that they've appointed a Chief Wellness Officer. It's interesting. So to her knowledge, 3 of them, of the 30 COVID-19 research and quality projects approved in the hospital service, 3 of them are directly related to staff wellness and resilience. One's about digital connection, and I guess one of the questions then, maybe Shane, is you talked about technology, maybe just with a minute or so, where you see the technology aspect of that starting to bridge these challenges.
Yeah, so I think probably picking up on what others have talked about as well, thinking creatively about engaging with different people through different technologies. Of course, in the context of domestic and family violence, there are pretty significant security and safety considerations that have to be worked through in a range of ways, and some ethical issues within that as well. But yeah, look, I think the recent experience has given an opportunity for people to think differently about how they use some of those platforms and technologies that are available.
Thanks, Shane. Really appreciate your presentation and your research effort. Thank you. So, look, that brings us to a conclusion. I know that we're just a little bit over time, but I did want to, just on behalf of everyone on the call today, just to thank the presenters, to Dylan, Yolanda and Shane for sharing the research work they're doing. We felt this was a really important topic to bring forward, and obviously we're very keen to get any feedback from you. So what I might do very quickly is, if you go to your application, if you have a look, the next question up on the screen there is about what you found useful today. And I would appreciate if you can very quickly provide us with a little bit of information there, and we'll see what comes up on the screen, and then we'll finish for today. So what you found valuable, how we might improve this. Obviously, with the presentations today, we'll have them online and a copy of the video for folks who weren't able to see it today, and links to any of the people that you've heard present today. And obviously, for example, in Shane's case, there's a series of research projects there. There's a lot going on with Yolanda here and internationally, and with Dylan's work at the coalface with clinicians and supporting them. So very, very, very happy to get your feedback. Obviously, if you want to make contact with BDHP, it's just info@diamantina.com.au. I'm still trying to get the URL right. They're a bit confusing, but you can find it on our website. If you Google BDHP, you'll find our website. So thanks for those who are bringing the responses in. Really appreciate that. Everything seems to have worked reasonably well today, which is good. Making the technology work is always a little bit challenging, but I'll take this opportunity to thank the team in BDHP as well, Rebecca Bibby in particular, for pulling this one together today and making contact with our speakers and making sure this all went really smoothly. So thanks to Rebecca and the team, again in BDHP. Okay. So that concludes the discussion today. Once again, thanks everybody for making time. Very much appreciate the effort that everybody is making around COVID. And if you've got any feedback for BDHP on what we can do, please let us know. And so thank you. Have a lovely day. Stay safe and take care. And we'll see you in a few weeks' time, where we've got another series of discussions. We'll be bringing one up around ethics and governance based on the new recently released BDHP Passport Agreement version 2, which you can find on our website. And also, as I mentioned earlier, a reprise of the first session around the clinical trials development and vaccine development. So thanks everyone, have a lovely day, and we'll see you later. Bye-bye.